So once we have diagnosed multiple myeloma and we have got all the investigations, then we take all the information starting from the blood test, starting from the bone marrow report, and also from the genetic report. We then categorize multiple myeloma into three major sections. As I told in the previous video, to keep it simple, I would like to call it as low risk myeloma, intermediate risk myeloma, and high risk myeloma, whereas the textbooks mention it as standard, intermediate, and high risk. So based on these tests, then we categorize what the best treatment the patient should receive for that particular risk. Now, why is this important? Let me give you a simple example. The low risk myeloma patients, even they are given with standard treatment, may not even require to undergo bone marrow transplantation in a large number of cases. That means you can give them the standard targeted therapy, and with the standard targeted therapy, if they achieve the best response, that is less than 10% abnormal plasma cells in the bone marrow, with the blood tests such as immunoglobulin levels and the serum protein electrophoresis and immunofixation all being normal, this patient can just be maintained on medications only and transplant may not be mandated. Now, the story changes once we go to intermediate and high risk. In the intermediate risk, we do not have to give a very high intensity treatment for multiple myeloma, and the chances of response and disease remission is very high when we treat these patients on protocols for intermediate risk. And with that intermediate risk, you will find that patients will receive a very good tailored treatment so that the myeloma cells can be reduced to less than 10% in the bone marrow when we do a reassessment. Now, these patients ideally should be taken for autologous bone marrow transplantation, after which their rate of disease control is very good. I will come to the statistics in a bit, but the intermediate risk patients do a lot better than high risk patients after they undergo bone marrow transplantation. So, what happens to the high risk myeloma patients? High risk myeloma patients are considered to be extremely aggressive and extremely refractory to the current available therapies. So one way to make them respond better is by giving them the latest targeted therapies, latest monoclonal antibodies that have been discovered in the last 5 years and have also been proven in the last 5 years. So we have to ideally treat them with those kind of therapies to achieve the best possible response. Once they achieve the best possible response, they can be subjected to autologous bone marrow transplantation, wherein they take your own bone marrow, treat you with high dose chemotherapy, destroy all the myeloma cells possible inside the bone marrow, and give the stem cells or the bone marrow back to the same patient. That is called as autologous bone marrow transplantation. After the autologous bone marrow transplantation, patients have to be continued on maintenance, and despite that, there will be a large number of patients who may come back with the disease, or what is called as recurrence of the myeloma. So that is the characteristics of the high risk and the intermediate risk and the low risk myeloma. So please remember one thing, very, very important to remember, is that all these patients have to be treated with certain kind of therapy, number one. Number two, all these patients have to be consolidated with either a bone marrow transplant or by what is called as consolidation therapy through injections. And all these patients ideally have to be given maintenance therapy. That means either a tablet every day or an injection once every 2 weeks to make sure that the myeloma cells are controlled for as long as possible. So as per statistics that we have, we see that the low risk myeloma patients can survive upwards of 7.5 years and even beyond with the standard therapy available today. The therapies that are available for intermediate risk myeloma can ensure that patients will be living for more than 3.5 years and beyond with the standard available therapies today. Whereas the high risk myeloma, despite our best efforts, we do not have many patients living beyond 1.5 to 2.5 years with the standard available therapies today. So the risk stratification helps us to understand how aggressive is the disease. The risk stratification also helps us to understand what and how long this patient is expected to live. The risk stratification ensures that we give the best therapy for each of these categories so that the best possible disease control and survivals can be obtained. So that is the purpose of risk stratification. Now, there could be a question as to, is there a role for allogenic bone marrow transplantation? That is, you take the bone marrow from a normal individual to a myeloma patient after the patient has received the intense treatment. The answer to it is yes. It is actually a very valid therapy for patients with multiple myeloma, especially in the high risk and the intermediate risk group. However, the risk due to transplantation by giving stem cells from another normal donor is higher than that that you see with the autologous transplantation, where the risks are very low. However, the cure rates when the transplant is successful are much higher with allogenic bone marrow transplantation compared to the autologous bone marrow transplantation. So, if you have any questions about any of these specific questions in myeloma, please notify us. We will definitely answer them back or even create another video on myeloma. Thank you.